Look at all these beautiful humans. Awesome, good to see you here. We literally are sandwiched between Evan and President Biden. I don't know how, did we draw the short straw or what? It's a pleasure to be here. It's a pleasure to be here with my fellow panelists. As the moderator said, my name is Brian Maloney. I'm a senior director at Genentech, which is a biotechnology company based in San Francisco. We're also one of the proud sponsors of Victory. We have been for a number of years. It is a source of pride for us, and I'm incredibly thankful to have an employer like that. I also have the privilege of being on the Victory Institute, which has really been just an honor to work with Evan, the rest of the team, my fellow board members. And so I know we've been giving it up for them, but I really think we need to give it up for them one more time. So Evan, Elliot, team, amazing job. Put on the old readers because my eyes are old. Okay. I forgot to mention that my pronouns are he, him. I'm going to ask each of my esteemed panelists to take some time to introduce themselves, why they're here, the role that they're in, and give them a little bit of latitude to freestyle. So with that, I will turn it over to my right.
Thank you, Brian. Good afternoon, everyone. I'm Vernetta, Alston. My pronouns are she, her. I'm serving my third term in the North Carolina House of Representatives currently. Thank you. I want to start by sharing this. North Carolina has the unfortunate distinction right now, I think, of being the only state in the country without a comprehensive state budget. That has some unique challenges to it in the healthcare space, but also more broadly. But I think like other states, when it comes to healthcare access and health equity, North Carolina is really a study in contrast. On the one hand, we've recently expanded Medicaid access to almost 700,000 people. And in so doing, we've also invested in rural healthcare and crisis center access, which has certainly helped support many LGBTQ folks in our state. We've also invested tens of millions of dollars into urgent behavioral health needs and in research. And those investments are absolutely saving lives in our state. On the other hand, we are facing some really extreme provider and program cuts. We are dealing with an extreme wave of anti-LGBTQ policy that is most certainly undermining our healthcare system. And I know we're all figuring out how to brace with federal cuts, but I'd say for me in my area, the real impact is being felt in our health research infrastructure, which is consequently affecting our economic momentum and I think future viability. I'd say for folks in this community, for LGBTQ folks, for folks in communities of color, they are, in our state and I'm sure in others, dealing with that contrast in a deeply personal way every single day. And I think that reality is the core measure of whether or not our system is working at all for anybody. I'd contend that it doesn't, which is why this is a huge priority for me and my colleagues back at home. So thanks, Brian.
Thank you very much.
Good afternoon. My name is Julian. My pronouns are he, him. And I'm a state senator in Massachusetts. I know we got Massachusetts in the House. In my 9th year in the Senate, I represent a part of coastal Massachusetts. I don't know if folks have ever heard of a little town called Provincetown. But before getting elected to the state Senate, I actually worked in public health. I worked for our state's Department of Public Health and really got into public policy and public service through a whole host of LGBTQ healthcare. I know actually we have our LGBT Youth Commission who's in the House as well. Used to be a member of that. And you know, really, when we're having a conversation about health equity, this is actually absolutely core to how LGBTQ people have engaged with government, have challenged government to be doing better. And if you really look at how so many of us and how this movement really got started, right? What does this come out of? This comes out of the watershed of the AIDS crisis. This comes out of efforts to redefine homosexuality or gender dysphoria not as diseases under the DSM. You know, the entire concept of intersectionality, which is throughout health equity work, right? That comes out of the work of queer folks like Audre Lorde, and others. So I think it's just really important in this conversation that we're grounding ourselves that health equity isn't the sort of nice to have thing. It, in many respects, is how LGBTQ people really started having to fight to have a seat at the table, because we were, effectively, seeing very big chasms and gaps in health equity, and we continue to see that today. So delighted to be here. I do serve on a number of panels related to healthcare, and I've done a lot of that work in the Senate, and it'll be a great conversation. Thank you.
Thank you.
Hi folks, I'm Caroline Medina. I use they, them pronouns, and I'm the Senior Advisor for Data Policy and Strategy at Movement Advancement Project. Delighted to be here with you all today. I am, identify as a data nerd, so I'll bring some of that perspective, I think, to today's panel. We're really focused right now at MAP on promoting accountability and scientific integrity at the federal level, as we're seeing removals of data on LGBTQ populations, which is posing a huge barrier to understanding the experiences and outcomes of these communities with respect to health, in addition to a whole host of other policy areas. And at the state level, we're really interested in supporting good data governance. So not just collecting, but protecting these data and making sure that that decision-making is being informed by community perspectives and folks with expertise on collecting and protecting these data. So excited to be here with you all today and for today's conversation.
Hello, everyone. My name is Benjamin Brooks. I use he, him pronouns. I serve as the Interim Director of Policy for the Institute for Health Research and Policy at Whitman Walker. For folks that don't know, Whitman Walker is a local LGBTQ community health center. We've been in Washington, D.C. for over 50 years, and I'm really grateful to be able to bring the perspective of community health centers to this conversation. Community health centers are a relatively recent innovation in our healthcare system that really believes that culturally appropriate and linguistically accessible services are what people deserve, and they're the front line of our healthcare system to ensure that people have access to the healthcare services that they need to stay healthy and to be included socially and economically in our communities. And so I'm happy to speak to the way that community health centers are impacted by the policies of the current administration and what we can do looking forward to make sure that we're around for the next 50 years.
Good afternoon, everyone. I'm Alderperson JoCasta Zamarripa from the city of Milwaukee. I'm honored to be here with such an esteemed panel today. I did serve a decade in the state legislature in Wisconsin before I moved on to local government. And I really appreciate Elliot thinking of me for this panel. He remembered before I became an elected official, I worked for Planned Parenthood of Wisconsin on both the C4 side as an organizer, and then ultimately came over to the C3 side as a community educator. And so I have been a champion for public health and the health of our community, so very flattered to be here with, again, such esteemed panelists. And I would be remiss, I come with a delegation from the great state of Wisconsin, and I'd be remiss not to give a shout out to a couple of my locally elected queer folks that are in the audience. From the city of Madison, the first trans alder ever elected. Alder Dina Nina Martinez Rutherford is back there. And if I may, she's running for state assembly and will become the first trans state legislator in the great state of Wisconsin as well. So remember her name. And you're going to hear about him more as we get into our dialogue, but the first openly gay elected alder in the city of Milwaukee, Peter Bergelis, is right next to her. All right, I know I took a lot of time doing that. My pronouns are she, her, and I'm excited to get into it.
Excellent. Thank you, everyone. Before we do get into it, before I try to do my best Oprah, I was thinking, should I be Oprah or Andy Cohen? I was like, what do I want? So I'm gonna try to do a mix, keep it serious, but a little bit light, and you can let me know at the end of this how I do. But I think what I'd like to do first is, anytime we're talking about healthcare, especially in the United States, it's so complicated, it's so multi-layered, there are so many actors that are involved, there's so much going on right now, hence this panel. And what I'd like to do is invite Caroline up, who's gonna kind of set the table for us to talk a little bit about what we're seeing, what the impacts are, and again, with I love the data nerd proclamation. So let's
Yeah.
Welcome. Yeah, if you'd like to, please. Thank you, Caroline.
Great. Well, thank you all again for having me. I'm really excited to be here with you all. As we discuss the shifts that we're seeing in Medicaid, the ACA, and other major health policies today, I think it's really critical to recognize that these changes are landing on LGBTQ communities that are already facing persistent inequities. And those inequities are driven by systemic discrimination, stigma, violence, and other social determinants that continue to shape access to care, chronic disease outcomes, as well as services that we all rely on. Against that backdrop, we are now facing policy changes that are creating and accelerating harm. The current administration is acting aggressively through executive orders and other measures to dismantle civil rights protections based on sexual orientation and gender identity, to restrict federal funding for essential health care, and to not only eliminate, but at times weaponize data collection about LGBTQ people. They've also cut $800 million worth of LGBTQ-focused health research, severely weakening researchers' ability to produce evidence that drives policy solutions and public health interventions. Combined, these shifts are making healthcare less safe, less accessible, and less accountable for LGBTQ people. The reconciliation bill that was signed earlier this year will enact the largest Medicaid cuts in history. Nearly $1 trillion over 10 years, and 10 million people could lose Medicaid, with another 4 million potentially losing marketplace coverage. For LGBTQ people and other underserved communities across the country that heavily rely on things like Medicaid, this is especially devastating. Cuts on this scale threaten the stability of entire health systems, from rural hospitals to HIV clinics to FQHCs, as we'll hear more about today. On top of that, at the state level, we're looking at an extremely fragmented landscape. 14 states and DC have adopted shield laws protecting access to gender-affirming care, while more than half of the states have passed bans on best practice care for trans youth. These policies are creating fear, instability, and interruptions in care for patients and families, and they're undermining providers' ability to deliver consistent evidence-based treatment. The challenges that government leaders, advocates, researchers, and the LGBTQ community are facing are significant, but I'm really encouraged by the commitment and dedication that I have seen at this conference and also just across the country to protecting people's health and supporting one another. I look forward to discussing with my fellow esteemed panelists today concrete strategies that can really help communities navigate these shifts and strengthen access to care. Grateful again for this conversation, and I'll pass it back over to you.
Thank you, Caroline. Okay, the first question is for our elected folks. So Caroline, I'll give you a moment to catch your breath and settle into the seat. We've talked a little bit already about Medicaid and the challenges that we're seeing at the state level, whether it be new procedural requirements such as work requirements, paperwork requirements. We're sort of we're seeing impact from a very onerous perspective. Obviously, there's a huge disproportionate impact to Black and Latino communities. And wondering for our elected officials, what do you think can be some of the avenues that we can best mitigate some of these procedural disenrollments and prevent further loss of coverage? Obviously, we think broadly, so I encourage you to think about, in your response, folks who are living in urban areas, our rural brothers and sisters, and yeah, so maybe we'll start with you.
Sure,
Thank
absolutely.
you.
Yeah, no, I appreciate the question. I think to your point, the challenge with Medicaid access isn't really about eligibility. I think we've demonstrated that in North Carolina through our expansion numbers alone. It's about political gridlock, it's about red tape, it's about these procedural hurdles. And so I think in order to try to prevent some of the coverage loss, some things we could do. Again, this might be a little bit unique to North Carolina, but it's first and foremost stop the policy-driven chaos. We're in a situation where we could stabilize Medicaid funding just for right now, for this year, and the majority in our legislature is choosing not to do that. And as a consequence, our Health and Human Services is it's forcing them into emergency cuts that are paralyzing our providers and our patients. So one, kind of stop the madness. Two, we need to expand automatic renewals and data matching. If folks are already income eligible for healthcare access, they should just be renewed automatically and not have to deal with burdensome paperwork and processes that are threatening their care. We need to fund navigators and community-based enrollment groups, especially for our folks in our communities of color, and certainly folks in our rural communities who are most impacted by these procedural disqualifications. And finally, I'll say, we need to protect folks during recertification. I think we can do more to provide that safety net. Folks shouldn't lose access to cancer treatment, to HIV medications, to behavioral health care, simply because the mail is slow or their form is getting lost in the mail. That's an absurdity that we can address. It's not a partisan issue. It should be one where we, as government, decide to organize ourselves around people rather than paperwork.
Thank you. Yeah, that's great.
Yeah, I think this period with these Medicaid cuts are going to actually instigate, I think, one of the toughest moments that for those of us in state legislators who are appropriators are going to really have to figure out and navigate. I mean, just for Massachusetts, OB3 alone in FY27, which we're going to take up, is about a $1.1 billion cut. We already actually saw cuts in this fiscal year that were $600 million. We had actually baked in an $800 million cushion, expecting the Michigas and sort of what would happen. But really, this is going to make really tough choices, even for a state like Massachusetts, right, where we put in quite a bit of our own state money into what we call our Mass Health program, our Medicaid program. But even for a state like us, this is going to be pretty catastrophic in a lot of ways. What our Mass Health program is trying to do now is to figure out, all right, how do we have other sets of data within the state that we can cross-reference and use to make verification, eligibility, as sort of seamless as possible, right? Using technology to basically meet the letter of the law, but really avoid the intended consequence of this law, which is basically just to kick people off of Medicaid because they didn't get the paperwork on time. So there's a lot of work there that's going on, but we're expecting, in addition to some contraction in revenues, we're looking at our next budget having about a $3 billion hole, a gap, building our FY27 budget. We've got about a $63 billion budget. That's really tough decisions that we're going to have to make. The other chunk of this work is then figuring related to LGBTQ healthcare within Medicaid conditions of participation, how under the Affordable Care Act, they've basically rewritten the rules around what's considered an essential benefit that no longer includes a number of key LGBTQ health priorities, certainly gender-affirming care, we're worried about HIV care, and then figuring out how does your state law intersect with that. And actually in Massachusetts, much of the protections that we have had for health care coverage predate the Affordable Care Act. So at one point we thought we were gonna have to go in and basically rewrite a bunch of stuff. And then we actually figured out, wait, no, we've predicated a lot of this on our non-discrimination law, which actually predates ACA regulatory implementation. So it very quickly gets deeply complicated, remarkably depressing, and these are really kind of hard, difficult challenges. But I think especially for state policymakers, getting some fluency in how your Medicaid program's working, understanding the big picture, and then figuring out, again, depending on the politics of your state, what you can do to protect particularly LGBTQ health priorities within that space is going to be critical, and we've been really trying to do that work in Massachusetts, and frankly, get ahead of whatever the heck the feds are going to try to throw at us next.
Just want to say quickly, you mentioned your budget gap. North Carolina is saying, hold my beer. Our budget gap is going to exceed that by the tens. Just that's all.
Yeah.
Well, at the local level, and I was just talking to our City of Milwaukee Health Commissioner Mike Todoritis yesterday and this morning in getting ready for the panel, and what he wanted to stress is that absolutely this politicization, if you will, or the difficulty with getting for folks to be able to apply, whether it's Medicaid or the additional scrutiny on all of our safety net programs, absolutely that's out there. It's a challenge that our constituents are facing. But what he wanted me to push out, and I don't know that he realized I was in DC at an international conference, but we have a website healthymke.com that we want to really break down and make it seem accessible and not intimidate our constituents from being able to figure out what they need to do to access health care. So we have a website that's available in multiple languages, English, Spanish, Hmong, and more. I was just looking at it this morning. I had it pulled up on my phone. I love it because we have these local navigators that Commissioner Todoritis and I are so excited about, because you can pick up the phone and talk to somebody in Milwaukee that can help you navigate healthcare and get signed up. You can also DM if you're a millennial or a Gen Z and you want to DM them or chat with them, or you want to call them on the phone, or you want to do it on your own. It's all laid out here too, because a lot of people don't want to deal with people at all. So that's something that we're devoted to. That's what he's committed his team to doing, in going out across the city and trying to get in front of regular folks and make sure that they know that that they have everything they need to try to access healthcare right now, when they're doing everything they can to limit our constituents' access to healthcare.
Thank you for that. I think two things, a reflection on how we're describing the situation. I've heard absurdity and mishigosh, so let's keep sort of the descriptors coming along. I can think of some others. I'm a New Yorker, so it usually involves an expletive, and I will spare everybody that from this stage. You know, just a point that was raised earlier around these gaps in care can really be catastrophic. Missing your medication or missing an appointment is really a tremendous setback for many, many people. And so we're going to talk a lot about numbers today, right? We're talking about financial impacts. And I think for me, and then certainly when I work with my colleagues in this space, it is really kind of anchoring always back to the person. And this is such a personal topic that we're all talking about. Every single one of us needs care, or will require care, or a loved one requires care. So I think the more that we can elevate that personal story when we're doing our advocacy and talking to elected officials, I think holding the person at the center of all this is a really important thing. The data and the numbers can surround all of that, but we have to make it a human at the end of the conversation. I'd like to invite in Ben and Caroline to the conversation, so your break is over. You know, one of the things I think certainly, and Julian talked about, the advocacy that was born of the HIV epidemic, and you know, really how the community writ large rallied and pushed for these tremendous changes in the healthcare system, and the sort of the rollback that we're seeing. But there's chronic conditions that a lot of us are faced with, whether it be diabetes or heart disease. We're very, very fortunate now to include HIV sort of in that chronic condition bucket. And I would love to hear a little bit from both of you around what sort of like non-policy barriers are sort of pushing down or being exacerbated by these new financial threats. I'm thinking specifically from a Whitman Walker perspective, where you're a point of care, right? So if maybe both of you could reflect a little bit on that, that would be great.
Sure. So for those who aren't familiar, Whitman Walker provides about a quarter of the people living with HIV in the District of Columbia with their HIV care and treatment, and about a quarter of those who are accessing PrEP get it through us as well. This is, for those, we only have 20,000 patients, so that is a huge proportion of our patients, and a huge success story. The reason that we have been successful, and our retention rates are extremely high, our viral suppression rates are among the highest in the nation, and that's because people know that they can come to a place where they can trust their provider and get access to services where people are not going to look at them sideways. And so these issues of stigma and trust are sort of at the forefront of our minds when we look at policies like work requirements. Then we look at policies that really have a dignitary harm involved in them. When you have to go back and reapply for the same benefit, this is emotional for me. I grew up in Georgia as a beneficiary of Peach Care, and I have distinct memories of my mother having to go every 3 to 6 months and do the paperwork again whenever we needed to visit the doctor. And it's embarrassing because it's a tax on the time of poor people. And that's what these policies really are. They're invented to dissuade us from accessing care that we have a right to. And so how we make sure that the places and the people that we are being when we are delivering those care, when we're involved in a care encounter, that we use our human capacity to soften the hard edges of our system, that's really important to us. And that takes time and energy, but it also is a cultural product that flows down from the very top. And so I really am encouraged to be in a room full of LGBTQ elected officials because you have the power and the expertise of rallying actual people power to change the circumstances on the ground. Our healthcare systems are being squeezed from the resource side. About 40% of the Medicaid population are people living with HIV. That's compared to 15% of the US population on Medicaid writ large. So that's an increase there specifically for people living with HIV. We know that each case of HIV that you divert saves about $500,000. And so the numbers and sense of our policies would on paper sort of advise us to make HIV treatment and prevention tools as widely available as possible. But our policies aren't designed to do that. They're designed to push people to the margins and push them out of public life because our culture has decided that people living with HIV somehow aren't included in our communities. And so we have to sort of proudly create an alternative narrative that pushes back on that lie that says, no, a disease doesn't take you out of our community. In fact, we need you to be here because the people should be treated as partners in disease control and prevention, not as vectors of disease. And we know that those kinds of policies and practices really work. A note on stigma, right? We just saw the publication of the horrible, inhumane public charge rule coming out of the current administration, echoing what they tried to do 4 years ago, telling our immigrant communities that they are not worthy of care and support. The similar thing that we saw with Grants Pass this past summer, criminalizing homelessness, telling homeless people you don't deserve to even exist in public space, even if you don't have a home. These are all part of the same story, trying to push people out of our communities and out of our public spaces, and ultimately making us less safe and less healthy. I'm almost done. We've also seen at HRSA, at CDC, and at SAMHSA these policy statements that are counter to the evidence-based policies that we know work, harm reduction policies like needle exchanges and supervised injection sites, evidence-based policies like Housing First that says before we want to try to make sure that you're taking your medications, we want you to have a safe place to sleep. These are the kinds of policies we know work, and these are under direct attack by our current administration. So how we speak truth to power is very difficult when we feel that the truth has been well established. For the last 30 years, we've known equity is important. So how we change the name of the game, I think, is really about building collective power so that the truth has an ear that is prepared to listen to it.
I mean, that's a tough act to follow. But no, I mean, Ben is absolutely right. These are devastating cuts that are really exacerbating existing inequities. You talked about chronic health conditions. Folks rely on this coverage for a whole host of healthcare services. 1.2 million folks that are covered by Medicaid are LGBTQ. So this is really hurting people just in their day-to-day life and in their ability to be healthy and to thrive. Economic insecurity is already a long-standing issue for many folks in the LGBTQ community, and so this is unfortunately really compounding barriers to care as we know them.
Thank you for that. We've talked a lot at this conference specifically. We talk about it amongst our communities, amongst our friends, about the disgusting dialogue truly around our trans siblings. And I think yet again, it's a portion of our community that is really taking the brunt of such hatred and vitriol, and you're seeing it play out in, unfortunately, too many aspects of our lives, and I think you're seeing it also in healthcare. We've talked about that, and it's incredibly disheartening. I think, certainly we're seeing the immediacy of denial of care, but I think there's also a cascade effect that we're going to see, including impacts to providers that will or will not treat because they're afraid to do so based on the state where they live. And so I kind of open it up to the entire panel to talk a little bit about, reflect on what you're seeing in your state, either good or bad, personal anecdotes. But I think it's an important and critically important aspect of this overall conversation, if not central to it.
So I think in Massachusetts, we were very sober and honest about what was going to come in this administration as it relates to gender-affirming care and as it relates to attacks on trans people, and literally started, since last November in really planning and plotting and figuring out how we could work first among our legislators, within our executive branch, right, led by Maura Healey, right, an openly, a lesbian, an amazing leader, who, by the way, was supposed to be at this conference, and unfortunately, we had a colleague in the House of Representatives who just died, lost her battle to pancreatic cancer. And so that is why Maura Healey is not here with all of you, but I want to send greetings from Governor Healey. Working with our community health providers, we have great research institutions, we have great community health centers like Fenway and Trans Health in Massachusetts, right? All of them, though, if you look at the way that we have sort of built healthcare access, whether it's in an affirming healthcare space, in an HIV space, a lot of this are tapping into programs that were set up in part with tentacles from the federal government, right? Our federally qualified community health centers, the 340B pharmacy program, tens of millions of dollars in research, right, that's coming to institutions like Children's Hospital in Boston, Mass General. That means the federal government, right, has quite an ability, if we didn't get savvy, to basically prevent gender-affirming healthcare in Massachusetts simply by kind of either turning off the spigot, changing the rules, and exactly what they've done. So we have been working really, since January and sort of plotting out how we were going to basically provide a way to ensure that there's care in a different fashion, right? How we've been providing care through FQHCs, through 340B programs, through research hospitals, that's not gonna cut it in this moment. And so we first built on the work that we've done. Massachusetts, I believe, was the first state in the country when we passed our SHIELD law in 2022 to include and to entwine gender-affirming care with abortion care. And that has been replicated in over a dozen states, and we're very, very proud of that. First, we went to update our SHIELD law, and we did so swiftly. That was signed into law by the governor in July. And then we also were trying to figure out, all right, how do we create a mechanism within state law that can be providing this care? And really big shout out, this would never have happened, without having colleagues at the table like Jack Patrick Lewis, like Thomas Moakley, like John Moran. These are representatives who are here from Massachusetts. And then I really teamed up specifically with San Montano, a state representative, our non-binary member in the House. And we wrote and came up and crafted this idea of an affirming healthcare trust, a mechanism within state government that provides a pot of resources. First, provides the authority to our Commissioner of Public Health, who, by the way, is an openly gay man, who got his start in his career founding an affirming healthcare clinic at MGH. So we create a trust that enables the state to provide care, to subcontract care, to provide liability coverage to providers who are providing gender-affirming care, to do research and training if needed. We seeded that initially with $1 million. We're coming back to put more money into this. This is something that I was proud to have co-wrote with San Montano. San Montano gets this filed to the House budget. Our House friends did a really good job seizing a little opportunity. There was a mishap in a vote in the House. And the House took this vote. I don't want to get too complicated in legislative, but they screwed up. And the LGBTQ caucus in the House seized the moment, got their colleagues on board when we took this budget, and we established this affirming healthcare trust in the House budget. The Senate concurred on it. It's now law. The governor signed it into law. We're now trying to figure out, all right, when conditions of participation are going to limit the ability for Mass Health to cover affirming healthcare, how much money are we going to need to put into that trust? We're trying to figure out what are the other needs. The Commissioner of Public Health is actually going to be using some of the dollars to help these entities that are outside of our traditional sort of community health space, right? Private practice, essentially, to be providing that care. And so that's exactly what's happening in real time. But it took a ton of collaboration. It took us, essentially anticipating that this was the world we're going to live in, trying to get ahead of that work. And then now we've got to really come up with the dollars to it. So something we're deeply proud of. And I'd really encourage states, particularly if you are in a blue state, if you have a trifecta like we do. I know California has done something similar and actually created a much sort of broader trust to do a whole host of things for trans folks and trans healthcare. But really glad to talk to folks afterwards if that's helpful. And really want to thank, all of my colleagues in Massachusetts who helped make this done. I think we're really proud to have led here. And I think this is a horrible, terrible, awful moment. But I think we're confident we can continue to provide affirming healthcare in Massachusetts no matter what the fuck they do.
That's awesome, Julian. I think Massachusetts is another example of leading the way, doing the hard work, and appreciate that. I am going to open it back up, same question to others, but one of the things about healthcare is everything has an acronym, and I know that not everybody may be ultimately familiar or intimately familiar with all the ins and outs of our dysfunctional healthcare system. So Ben, maybe you could describe what a FQHC is, please.
Absolutely. Gladly. So an FQHC is a federally qualified health center. We also include FQHC lookalikes, just because we can be more complicated. Essentially, we enter into a contract with the federal government that says we will be a healthcare home and will provide care to everyone regardless of their ability to pay. In collaboration with the federal government, we provide that care, and they provide us with sort of a sustaining grant that allows us to operate on a fee basis. It is a we have a very diverse payer mix, and so it isn't enough of a grant to keep our doors open. We have a diverse set of income streams, including the 340B program. I'm really sorry if today is your first day hearing about the 340B program. This is a whole session in and of itself. Essentially, it is a program that helps move dollars from insurance companies to healthcare centers so that we can provide more and better care to communities in need. We also we bill insurance like any other healthcare center, but we are required to provide care to people regardless of their ability to pay, which is what makes us different from a place like One Medical, for example.
Thank you for that, Ben. And I think just to pull on the thread a little bit further is, so when we're talking about all these cuts to Medicaid or ACA disenrollment, these individuals are going to end up at federally qualified health centers, which are going to be crushed in the onslaught of disenrollment policies. So again, people who are on the front lines doing incredible work, taking care of the most vulnerable in our society, and then certainly in our community. So thank you to you and the rest of the Whitman team who are doing that. Back to the rest of the panel, and maybe I'll turn to you.
Sure,
Thank
yeah,
you.
maybe by contrast to Massachusetts, North Carolina is a state where we do have very aggressive bans on gender-affirming care, on evidence-based care, and they come with really significant consequences for providers. And not only is the care banned, but there are very aggressive funding clawback provisions, threats of lawsuits, and that has a clear chilling effect not only on the gender-affirming care, but for care for everybody, for our entire health system. And I'd say, as a legislator, what I'm trying to do, and I know my colleagues who are similarly minded, is to try to roll back these provisions on principle, but to try to keep and attract providers to our state. We are trying to think creatively and it's sometimes begging for incentives for healthcare worker training and for retention because folks are leaving. The healthcare deserts existed and they are getting substantially worse. And I'd say also, we are kind of fighting this battle in other areas as well, because we're seeing the same playbook that folks have used, folks in the majority in my legislature have used to attack gender-affirming care. We're seeing that playbook play out in other health-related areas, health-adjacent areas, education, environmental justice. And all of those attacks are conspiring, again, to exacerbate, I think, just a broader crisis, to be sure, but certainly the existence and deepening of our healthcare desert. So I think one of the things I also want to do is help to broaden the coalition of folks who make this particular issue a priority, because it's impacting them as well. Thank you for that.
Yeah, and I wanted to talk about, and this is why I wanted to acknowledge my colleague, Alderman Peter Bergelis in Milwaukee. The question made me think of recently, we've never had a queer caucus at the city of Milwaukee. I was the first out elected alder in 2020, and then Peter joined just this last spring. And so we finally had a queer caucus, and we have set an ambitious goal of delivering for our community allocations to queer-led and queer-serving nonprofits. And together, the Queer Caucus, Peter and I, have delivered hundreds of thousands of dollars in support of organizations that support our queer community, in particular our trans community. But it hasn't been, it's been a Herculean task. At the end of 2024, beginning of this year, we worked on what we called the Council-Led Transformation Fund. This was the last bit of funding that we had from the federal government, and the council was committed to giving it back to the community via allocating to nonprofits. But Peter and I had an ambitious goal to set aside some of these allocations, again, for our LGBTQ plus community, in particular, our trans community. We had a proposal to give $150,000 to about 3 nonprofit organizations for a name change clinic for transgender Milwaukeeans, for emergency housing and emergency food services through Diverse and Resilient, an LGBT nonprofit. And we also wanted to give a small allocation to Black Pride MKE that was serving our Black trans community. But it was a huge task from having to whip the votes from our colleagues and make sure that we had their support, to the even more difficult task of having to make sure that we weren't risking all of the city's funding because of the threats from the federal government to local municipalities to yank funding if we're found to be serving LGBTQ plus, in particular trans, and immigrants. As you know, I'm sure many of our local electeds hear it from their city attorneys all the time that we better be careful, or all of the city's funding is going to get yanked if we're found to be serving the constituencies that we're passionate about. I am an embodiment of the intersection of serving immigrants in the city of Milwaukee, serving queer folks. As a queer Latino woman, these are the communities that I feel most passionate about protecting and fighting for every day. So you can imagine what we went through in trying to get this, bring this, and make this a reality for our communities. And there were a lot of fights with colleagues, fights between Peter and I, fights with the city attorney. But finally, with a little bit of creativity, just this last, I would say spring or so, right, Peter, we delivered $150,000 to support those 3 proposals, name change clinics for trans Milwaukeeans, emergency housing and food services through Diverse and Resilient, serving all members of our community, as well as a little bit to also serve the Black trans community for some roundtable discussions that Black Pride Milwaukee is hoping to facilitate. So this was a huge win for our community. And it didn't stop there. In total, we ended up in the last 2 years delivering $400,000 to queer-led organizations serving our community. But again, this almost didn't happen. It literally happened because we have 2 out-elected officials in the Common Council for the first time ever. And between me and Peter, good cop, bad coping it, we were able to bring this home for our community, but it almost didn't happen. That's right.
That's amazing. Thank you for sharing those examples. Caroline, Ben, I invite you into this question, if you have anything to add.
Yeah, I mean, I think there are dual impacts, right, on trans patients themselves, but also broader healthcare systems and providers that are tasked with providing this care. I think on the provider side of things, as was touched upon, this is a scary time for folks to be practicing. The restrictions that we're seeing have been focused mainly, but not exclusively, on transgender youth. But providers are, this being criminalized for practicing in accordance with standards of care and trying to help their patients. So I think it's scary, and there are huge interdisciplinary teams that often provide this care. And in these kinds of hostile environments, you can result in provider shortages because it is a really scary time. So that worsens care for everybody. And so I think that's just important to keep in mind the sort of cascading effects throughout the healthcare system.
Yeah, I mean, I think certainly a real parallel with what we're seeing also with women's reproductive rights in healthcare and denials in certain states and fear of providing those types of services. So I appreciate you calling that out. Ben?
Sure. I'll just add that everybody receives gender-affirming care in one way or another, cisgender, transgender. And so these laws and policies are absolute nonsense, and it forces each and every single provider or insurance provider or government regulator to be a gender cop. And that's not a thing that anybody, I think, wants to be in America in particular. And so I think it's clear that these go against our core fundamental values.
That's great. I love that. I'm going to use that line from now on. Let's talk a little bit about some legislative actions that we can be considering, certainly at the state and local levels. Julian, you touched on, well, actually, Caroline was the first one to touch on shield laws. Julian, you brought it up as well. Could, Julian, maybe you just take a moment to describe what a shield law is, how it works, why they're important, and then we can get into some of the other options that might be out there.
So the shield law is a series of protections for providers of given care. Many states, on the eve of when the Dobbs decision was essentially leaked, realized that our providers of abortion care were going to be gone after, and we're not going to have the series of protections they need, and really could essentially be bullied via liability out of providing care. And the same thing actually was already happening even before the Dobbs decision about providers of gender-affirming care, and you were seeing a number of states who had passed those laws as well. So the shield laws effectively is around a shield for the providers, the location, the health center or the hospital providing that care, and then in addition, a number of states our shield law is quite broad, right? So basically, the receptionist, anyone sort of involved in providing that care is protected within the confines of the state, and a number of, it's tough, right? So like I can give like a whole laundry list of advice for states where it's going to be possible for folks to bolster their shield laws, to pass an affirming healthcare trust like we did in Massachusetts and what California's done, to update the name change policy, which we just did. We had this pesky requirement, you had to publish your name in a newspaper. We got rid of that, right? And I also want to be really cognizant that we've got folks who are serving, who are not in environments, right, like a Massachusetts or a California. And so I think the playbook there is sort of different. I also think I'm always looking for sort of what's the opportunity going to be from a legislative perspective. In a way, we have been able to pass things in Massachusetts where I think for a while we had sort of rested on our laurels and thinking like, oh, we were like first in marriage, like we're so great. And actually Massachusetts had really fallen behind in HIV protection, in parentage, and a whole host of crucial policies related to LGBTQ folks. And we've worked to sort of seize this really horrible national political moment to get a bunch of stuff done, that hadn't gotten done. And so I think seizing those opportunities. And I would also encourage people to think, what is going to play out in the healthcare system is going to be an unmitigated disaster and a complete shit show. All of these people who are going to be shoved off their Medicaid programs are going to end up in community hospitals and in rural hospitals and in community centers without insurance. They're going to have to be treated because that's also required in the law. And this is just going to further burden an already broken sort of healthcare system. We don't know what's going to happen, right? But something's going to have to come out of this to further fix this. And so I'm really, already trying to think, all right, when that does happen, right, as we're looking at things in Massachusetts, as you're looking at things in your own states, what are sort of the opportunities that are going to come back in a health space when we do have to be repairing all this? How is health equity interwoven in so much of what we do? Part of the problems we see in our sick care system is that people are showing up for care, and they're showing up sicker because of a whole host of structural inequities, of poverty, of a whole host of things we haven't addressed. So that's what I'm really trying to think about, but I think it does vary, and I want to have some humility that it's radically different depending on where you're serving in those states, but you being in the room is absolutely essential, and that's why y'all are here.
Thanks, Senator. Representative, please, yes.
Yeah, I'll add to this quickly. I think first we need to fully fund Medicaid so that our community health centers, our rural health providers aren't constantly facing the threat of closure. And this next one might be a little bit North Carolina specific, but we need to stop the purge of DEI and diversity policies. And part of this gets to my earlier point. Some of the policy rollbacks and the bans that we're facing in North Carolina are absolutely impacting our workforce pipeline. I think we all know that DEI policies help us better serve the LGBTQ community, help us identify racial disparities, and also address barriers with rural healthcare access. Without it, bias grows, it flourishes, and access shrinks. I think the last thing I'll mention is, lost my train of thought. It's coming. Oh yeah, we need to expand workforce where our shortages are kind of at their worst. In North Carolina, we have struggled and still haven't passed a bill that would provide full practice authority for nurse practitioners. Just making that policy change without funding would immediately increase access to care, particularly in our rural communities. So that's right in front of us if we kind of take the opportunity to do it. So.
Thank you. Mm-hmm. Alderperson, you were talking a little bit earlier, so inspiringly actually, about the different things that you're doing at the local level, and I wanted to turn it back to you to sort of tease that out a little bit more. What more can be done at the community level, and what you're seeing play out in your community?
Yeah, I wanted to just keep going on this example that I used about the difficulty, though ultimately victorious, of delivering those allocations for our community. Again, and I know I kept stressing it almost didn't happen. I wanted the conference attendees to realize how difficult it is. And it would not have happened, and I couldn't have done it by myself when I was the only out member in 2020. I can't tell you how difficult it was. In fact, I know I don't have to tell a lot of you because there's so many firsts in this room, but it was very hard to be the only one. One is the loneliest number. I had members that really struggled with understanding and supporting our LGBTQ plus community. And so having Peter there with me to advocate during a time when the city attorney was pulling us aside and saying, it's not gonna happen, guys. We cannot serve these organizations that are explicitly serving LGBTQ plus folks. It's just, you put the city's entirety of the federal funding that we receive at risk. And were it not for Peter and the fights he and I got into, because again, I tend to lean on the nice side and he leans on the a bit more assertive to maybe aggressive side. And if it wasn't for us having that back and forth and feeling so passionate about our LGBTQ plus community because we're queer electeds, and bringing the city attorney into the room with the two of us and having staff from the nonprofit organizations that we were hoping to allocate to have that conversation and brainstorm together and finally get the city attorney to realize, guess what, we can make these allocations because diverse and resilient, the other nonprofit organizations that are escaping me right now, all serve whoever walks through their doors. Straight, queer, trans, cis, they will serve whoever walks through their doors. And the city attorney realized, oh, then we can do this. And that was how we were able to deliver it. And we wouldn't have done that if we would have just stopped at, the city attorney calling us up and saying it's not possible to serve these orgs that clearly are just queer-led, queer-serving. And so I think that the innovation and the advocacy that needs to be done really is, and I think Victory Institute and Fund would support this, is making sure that your governmental bodies have multiple openly LGBTQ plus members, so that we can have a caucus that truly fights for what we need, whether it's access to healthcare, access to affordable housing, access to food. We need to make sure that we have out queer electeds fighting, and we need multiple members, because I'm telling you, I was there, the only one, and it's just so hard to do it. We got to make sure we have a queer caucus in every single governmental body, at the state level, at the local levels, at the federal levels.
Thank you for that. I did a slightly terrible job moderating in terms of time, but you'll all be relieved to know that the star of the show is going to be here imminently. So we're going to wrap things up now. That was incredibly inspiring. You all inspire me. I think what we're seeing here is that it really does take a village. I mean, and we have to be in these rooms. We have to be speaking up for people that are not at these rooms, not sat at the tables. Thank you to everyone in the audience who's playing your part, wherever that part may be.